just let me give you some statistics. As of today, we have close to 20 million cases, and the number of deaths is over 700,000. And we are more concerned about the death rate of older people, such as in the US, 80% of deaths are 65 and above. And in Hong Kong, we have an even higher percentage. We have 90% of our deaths are people 65 and above. So statistics have revealed that COVID-19 is age-related. That means the older you are, the risk for developing serious illness and death from COVID-19 will be higher, especially for those 85 and above. So all countries and cities are developing different innovative approaches for the elderly to combat COVID-19. So I guess this is why we are all here today for this topic on global innovative programs for the elderly to combat COVID-19. So the webinar is co-organized by ACAP, Active Aging Consortium in Asia Pacific, and Golden Age Foundation. And we are grateful to have 5 distinguished speakers from New Zealand, UK, Singapore, India, and Hong Kong to share how the governments, NGOs, and citizens have addressed the issue. And also they will present their insights on the way forward. So before we start the presentation, I would like to invite the co-organizers of the webinar to say a few words. So may I first invite Professor Catherine Brown, President of ACAP and Professor of Public Health and Social Work from the University of Hawaii to address us. Professor Brown, please.
Aloha, aloha, and welcome to everyone on this webinar. It's so exciting. It's so exciting that we're doing this and all of the learning that has happened as we have stumbled through with all of these Zoom technologies. But I'd like to give you a little bit of information about ACAP and invite you to join if you're not a member. So ACAP is a group of very fun gerontologists. So we're from all over the world, and the main thing is that we're very friendly, and we like to share information about innovations in active aging. So things that keep older people active and productive. We have a bulletin that comes out every other month, and I invite you all to participate in that as writers. You get your photo, your article, and a lot of good feedback as we share your innovations with everyone. And we also now have started this webinar series. This is our 3rd webinar, and we will have another one August 22nd and another one after that. We don't have a date yet for that, but we invite you to also present. If you'd like to present, we're looking for speakers from Malaysia, from Taiwan, Mongolia, Australia, many countries that haven't yet presented here. If you want to join, I put my email address in the chat already, so you could just send me an email and I'll add you to our mailing list. The best part of ACAP is it's free, so please join us. It's just a privilege to partner with Golden Age Foundation, with Rebecca Choi, who I've known now for a couple of years, and she always puts on a fabulous conference, the Golden Age Foundation conference every year. It's just very exciting that we can partner through Zoom. A lot more people can participate in this information sharing. I'd also like to thank Teresa, who is the ACAP representative in Hong Kong. And Teresa and I have known each other for a number of years and become very good friends. And I have appreciated all of the good work that you did with Hong Kong Polytechnic University and the Jockey Club and many other venues there to bring active aging to Hong Kong. So thank you very much for moderating. And to everybody, enjoy your time. send your questions in by the chat, and let's hear our speakers. Or let's hear first from Rebecca.
Thank you.
Thank you. Yeah, so may I now also invite Mrs. Rebecca Yong. She is the founder of Golden Age Foundation to address us. Rebecca, please.
Thank you, Teresa. Aloha, 欢迎, 欢迎. A big welcome to Catherine, members of ACAP and Golden Age Foundation, as well as friends from near and far to the virtual Golden Age Summit. We started this morning with a series of very informative and insightful sections covering different aspects of the aging society, and we are looking forward to see how we can build a new normal together. In fact, the pandemic has put the entire world to the test and exposed many gaps that we need to fill in. It has also showed the lack of preparedness and resilience of our highly interconnected economy and our aging societies. But as Teresa mentioned, the elderly is the most vulnerable group. So how to safeguard the health and promote the well-being and quality of life of our citizens, especially the fragile ones, during the pandemic and after the pandemic is a big issue that we need to focus on. And we've seen that in the face of the adversity, a lot of civic innovations has taken place. And I would say that the civic society in many places has moved much quicker than governmental institutions. So we are seeing a lot of community-based innovations at the grassroots level throughout universities and even secondary schools. Businesses are reinventing themselves to help respond to the outbreak, while at the same time adapting the models to continue to survive in a lockdown world. So this is indeed a time for innovation. So I'm very pleased to co-organize this section together with ACAP on global innovative programs for the elderly. I see this as a golden opportunity for us to use the crisis as a way to understand how to tackle future crises as well. So let us not let this crisis go to waste. Let us all learn from it, reflect on it, and build a new way together. So we are in this all together. Let us be the ones who future generations can look upon as an example of global solidarity and leadership. So I look forward to hearing more from the distinguished scholars here and to learn from how you have combat COVID-19 in your own country and places. So the Golden Age Summit will still be on tomorrow, but unfortunately tomorrow it will be in Cantonese. So if you would like to brush up your Cantonese, so tune into our website and log into it. Otherwise, we would produce a series of reports and also videos, so you could look at them later on. So thank you, and let us have a very, very fruitful discussion. Thank you.
Well, thank you, Catherine, and thank you, Rebecca. You know, this is the second time that ACAP and Golden Age Foundation has co-organized. So we look forward to many more collaborations, okay? Well, as we have 750 participants today for this seminar and coming from 14 countries. So may I propose to have a group photo with all of you as a keepsake for this webinar? So I guess Gary can help, right? Can we put as many people as possible on one screen, if possible?
I don't think so.
No? I don't think so?
I don't know.
So maybe we'll just do it ourselves then. Okay, so I'll take a photo. Please bear with me. Okay, look and smile. Okay, are you all ready for the presentations? Yes, I am. I'm going to introduce each speaker before they speak, and each speaker will speak for 7 minutes. At the end of all the 5 presentations, we have allotted 15 minutes for questions and answers. And during the presentations, if you have any questions, please send to the chat and I'll share your questions during the Q&A. Okay, thank you for your cooperation. Catherine, we are taping, right?
Yes.
Okay, great. So may I introduce the first speaker to you? The first speaker is from New Zealand. Dr. Brian Finson is a former professor of education, University of Waikato, New Zealand. He is also the former professor of adult education at the University of Glasgow. He has worked in the field of adult education in most of his working life. His main research interests include learning in later life, social equity issues, and international adult education. Dr. Finson has co-written and edited several books and published extensively in later life learning. He is a current council member for Age Concern Hamilton in New Zealand, an organization concerned about the well-being of older people. Dr. Finson, please.
Thank you, Teresa. Hopefully everyone can hear me. Thank you to ACAP for the invitation and to the Golden Age Summit for this occasion. I'm now going to attempt to share the screen, so bear with me for a moment. Can I just check that the slides have come up for you to see? And that you can hear me. Catherine, I can see that you are nodding. Thank you very much. Right, so in this short time, I'm just going to try and convey some ideas about what's happened in New Zealand in respect to COVID-19 and the situation for older people. So I'll provide a little bit of context of New Zealand, a little bit of context about older people in this country, before looking at a particular incident that happened in Christchurch, New Zealand, and a little bit about the Age Concern organisation that I'm a council member for, and finally, time permitting, looking at some issues in relation to COVID.
Brian, so could you please click on that one in the corner from the beginning? Screen. It says slideshow from the beginning. Yes. Yep. There you go. Thank you.
Okay. Thank you very much. Right. So that's in effect what I've just said. So now a little bit about the New Zealand context, and I think context is really important in terms of understanding how COVID has infiltrated or otherwise in the country. New Zealand has a small population, 5 million, around about the size of the UK, an island nation in the South Pacific with relative isolation. It's a long way from just about anywhere, long way to fly. We have a diverse population, although European domination, particularly through colonization, founded very much on egalitarian principles. And at the moment, we are still somewhat economically and politically stable. That's a map of the 3 islands, a small one right down the bottom, and I live in the city of Hamilton, which is in the northern part of the North Island, and 1/3 of the population is in and around the Auckland, Hamilton, Tauranga area. And further south you go, the colder it gets. Now, around about older people in this country, 14.5% of the population, which I think is reasonably common for a number of the other countries who are participating today. Who is an older person is a subject of debate, but the government awards superannuation at the age of 65, and it doesn't matter if you're the richest person or the poorest person, you receive that. There is no compulsory retirement, so a number of people, including people like myself, have continued to be in the workforce, and I'm 68 years of age and just still a little bit in the workforce. a lot of diversity in lifestyle, life expectancy, which is, I think, reasonably common that women tend to last a bit longer than men. And there's a lot of volunteering that goes on in New Zealand. And I'm an example of that in my role as a council member for Age Concern Hamilton. Now, this event here is actually the elder abuse day of acknowledging that elder abuse occurs in the country and what we can do about it as a nation. I'm just showing you some photos which we might argue is normality, you know, before COVID and perhaps even after COVID. So this is some intergenerational learning between Indigenous people, Maori people, and some high school girls. Now this is really the heart of the presentation, looking at what the government has done in terms of setting up 4 levels, which I think arguably have been reasonably easy to understand for the populace. So the level 4, which came in on March 26 in New Zealand, was where we had a complete lockdown. And this lockdown happened really quite suddenly. We're given 2 days notice, and people from all around the country scurried back to their home places as fast as they could. So essentially the complete lockdown, as the name suggests, you stay at home, you're in small bubbles, we call them bubbles or little networks, and only essential services really operating. People over 70 were identified as being the most vulnerable. There's been some debate about the use of a number to indicate that someone might be old, because I think perhaps we might speak of the most vulnerable people because of some 70-year-olds who are much fitter than some 50-year-olds. Then on the 13th of May, we went down from the complete lockdown to a more restricted period. Not as bad as the complete lockdown, but nevertheless serious in that people were not able to move around very freely. So there were clusters identified, places where there was most vulnerability to be shown, and testing and tracking started in earnest. We were allowed to have up to 10 people in what the government called a bubble that you could continue to interact with on a daily basis. People were told to work at home, and public venues were closed at level 3. Then some relief for people. On 30th of May, we went into level 2, a less restricted time, where there were groups of up to 100 people who could assemble. And of course, this had implications for the likes of schools and sporting events and so on. So public venues were open, including schools, and people could now travel anywhere within the country. And Air New Zealand, who had suffered dramatically from the shutdown, were able to operate within New Zealand, continue to operate. Level 1 started on the 10th of June, and that level 1 is called preparation to maybe go back to a more serious level. But from the 10th of June, things have returned to almost to normality, right? So there were no restrictions on personal movement. People are not wearing masks. All businesses are open. The only restriction that pertains right now is, in fact, the borders are closed off, except for people returning to New Zealand, who then have to go into 14-day quarantine. There have been some people who have attempted to break out of quarantine, and they have been sort of rounded up and not been very popular. Moving on, the government, I think, has taken credit quite rightly for the fact that currently, after 100 days, there's been no community transmission. And what I'm showing you here is that the government has, through newspapers and so on, continued to keep people informed on a daily basis. So we've had 22 deaths in New Zealand overall. I think about 14 of those were in one particular venue, which I'll talk about in a moment. And the vast majority of those people over the age of 65. There was a critical incident which occurred in Christchurch around a particular rest home called Rosewood, where there were 12 deaths. So that's 12 deaths out of the entire 22. So it was quite serious. This particular venue had a dementia unit, a hospital, and a rest home in combination. And when it was detected that someone had COVID, the 71 staff were removed abruptly from the place, which left things somewhat in disarray. So some vulnerable patients were sent to nearby Burwood Hospital. In fact, some of the people died in that hospital who had come from the rest home. So the reason I'm showing you this or talking about this is that this was the most critical cluster, so to speak, of the 22 deaths. You know, significant number came from this one location. And it created a lot of confusion for patients, for staff. To be honest, it was quite chaotic. So I think the government learned and the institution learned a lot about how to deal with things after this event. This Age Concern New Zealand is the organisation and the NGO that I belong to and have been for a number of years. There are 34 locations, including the local one in Hamilton City that I work for. You can see the number of different services that are on offer, and some of essentially Age Concern gets contracts, grants, donations. It exists financially in a number of different ways, but mainly through contracts through the Ministry of Health, where we have also visiting and shopping services, support services, people going out to older people and just having a cup of tea with them or something, or maybe doing their shopping, that kind of thing. Health promotion has been taken seriously, and particularly around mental health, because we know that some older people are particularly vulnerable to being lonely. And in fact, social isolation of older people is one of the major targets that government is trying to hit. So that's a little bit about Age Concern, and these are the effects, really. This is what we're trying to combat in the country: loneliness and the isolation of the elderly. Just to finish up here, to identify some issues. No doubt these issues apply in a number of different countries, but at levels 4 and 3 that I alluded to earlier, the really serious levels of lockdown, fundamental support needs to continue for older people. Marginalization of older people over the age of 70, this is a big question mark. Now this is a side effect, a consequence of COVID, is that there have been a delay of other medical conditions. And this is where things have got rather controversial in the country, particularly because people are feeling quite safe, relatively safe at present.
Hi, Brian. I'm sorry that time is up. Can you round up quickly? Thank you. Yes. Sorry about that.
Just winding up now. This is the final slide. There is an election coming up next month, and there is continuing politicalization of COVID, whether of strategies to continue to deal with this. So at the moment, we're in reasonably good shape, but we're not getting ahead of ourselves. So thank you very much for the opportunity to talk to you.
Teresa, you're on mute. Teresa, you're on mute, so you have to unmute yourself.
Can you hear me now? Okay. The second speaker is from UK, Professor Eve Hogevost. She studied health sciences at Maastricht University and worked as a research scientist at Oxford University and the University of Arkansas Medical Sciences in Arkansas. And she is also a senior research associate at Cambridge University before taking up a chair at Loughborough. Eve is an epidemiologist and neuropsychologist with a focus on healthy aging. She has published over 200 peer-reviewed international publications and is regularly invited for keynotes and lectures worldwide. She has obtained funding for more than £10 million for her reviews or her research with collaborators. So Eve sits on several advisory boards and reviews EU and other grants. She also holds chairs in Indonesia at University of Indonesia and University of Respati, where she has been conducting research since 2005. She is now serving as professor of biological psychology at the University of Loughborough, UK. So over to you, Eve.
Thank you very much, Teresa, for the very kind words, and thank you, ACAP, for the invitation. I'll try to share my screen with you. There we go. Can you see it?
Yes.
Yes.
Can you make it full screen?
I've made
Good.
it.
Great.
Okay.
So you have 7 minutes. Okay.
Great, thanks. So I'll be talking a little bit about COVID in the United Kingdom. These are some of the death rates from the European Centre for Disease Prevention and Control, which show how high the death rates are in the Americas and in the UK. When we compare this against some of the Scandinavian countries, and certainly the East Asian countries, where there was very clear leadership, a quick action, lockdown, testing and tracing, and the use of experts. Now, these are the overall numbers, and obviously they need to be controlled for population density. And if we look at that, if we look at the mortality rate, at the death per million, we can see that in the Americas, those numbers are still very, very high, and also in France, Italy, Spain, and the UK. Now, this came out at the end of June and was still similar data at the end of August, where the UK had the worst affected death rate per 100,000 in the EU. Spain and Italy have slightly older populations, so if you correct for that, the UK really stands out. So we've got a really, really high death rate per population rate. Now, the question was why that was the case. And one of the things that we could see is that, and there were some interesting articles about this, that huge gatherings were still allowed in Cheltenham and Manchester just before the lockdown. The lockdown was relatively late. It was on average a month after other EU countries. Airports didn't restrict arrivals or do any health checks on arrival. Mask use wasn't advised. It was only made mandatory in shops in July and public transport in July. And as Professor Neil Ferguson said, who was on the SAGE committee for pandemic control, he said, we could have halved the death rate, the excess death rate, by half, by 20,000 people, if we would have locked down a week earlier. We still don't have adequate testing, tracing, and isolating, and PPE for medical and care personnel is still not adequate, so very many people died. Who we see died most of all, as was said before, are the older people, particularly the poor, and ethnic minorities in the UK have been disproportionately affected. So a lot of people thought that from the newspapers that this was an old people's disease, that this was a disease for ethnic minorities. But in actual fact, what we see is that still 80% of the deaths occurred in white people and also middle-aged people. So this graph shows how locking down earlier could have reduced the excess death toll in different countries. And we can see that the UK is right up there. Now, this is data for age, and as we said before, definitely age is a risk factor, but not everybody who is old dies of COVID. So about half of the people in their 60s who are diagnosed will die. 3 out of 5 patients aged 70 and over will die. So there's definitely an increased risk, but it doesn't mean that young people do not die of COVID. And it also doesn't mean that all old people will die once they've been diagnosed by COVID. Men have a much higher death rate as compared to women over all the age groups, particularly overweight men who were bald, and it was thought that maybe testosterone played a role with this. So we've been trying out estrogen treatments for men. And the Black and other ethnic minorities. Black men have a 3 times higher risk of dying. Bangladeshi people had a double risk of dying from COVID. Now, particular comorbidities such as diabetes and hypertensive disease, lung disease, dementia are more prevalent in these ethnic minorities. But the other problem is that if we look at the data, these ethnic minorities are also much more likely to work in high-risk occupations such as healthcare, social care, and public transport. Also, a lot of the ethnic minorities, such as, for instance, in the outbreak in Leicester after lockdown was lifted, were found to live in very cramped multi-generational living conditions or in very cramped work conditions, and in fact were forced to work through lockdown illegally. Of course, we've seen a lot of the deaths occur in care homes, and this is quite interesting because here a lot of excess death occurred. 20,000 people died between March and the 7th of May, in addition to what was expected. So that was 2 times higher than what we would have seen in other years. 2 out of 5 care homes was affected by COVID. So that also means that 3 out of 5 care homes wasn't affected. So shielding for some of the care homes worked well. But one of the problems was that not all care homes made, for instance, PPE mandatory, and masks were often not worn, strangely enough. So somehow that message didn't get through to the care homes. Here we can see that 1/3 of all deaths in the UK occurred because of COVID in April, where we see the highest peak. And the most common morbidity, and this is something we study in Indonesia and the UK, was dementia. So a lot of people who died of COVID also had dementia. And here we see these numbers of deaths occurring in April. So we see a sort of quite a large outdrawn peak over the whole of April. And if we look at COVID, we can see that that contributes to some of those excess deaths, but not all. And this is really important because here we can see that excess death occurred particularly in the older people, where the older women were, the more likely they were of dying of non-COVID related disease in that period of time, particularly the older women. And they died, as it transpired, of dementia. That was most common on their death certificate. So these were frail elderly people and people with dementia. They didn't die in the hospital, where there was a 21% decrease of death registered, but instead people died in the care homes and died at home. And what we can see when we look at these data, so these are data from the Office for National Statistics, we can see that there was a delay in care, undiagnosed COVID, or suspension of care, as Brian just talked about. So it wasn't a reduced hospital capacity, but today a report came out strongly stressing that if we're going to look at another lockdown, we should not suspend care for the elderly, for other morbidities. And it seems from these data that the older people with dementia were just forgotten about and died of other causes. So everybody was focused on COVID, but instead a large number of people were dying of dementia and other diseases. So,
hi, Eve.
I'm sorry
sorry.
for taking you through this so quick.
One minute.
This is my last slide. So many of the deaths in the UK were avoidable. If we would have had an earlier lockdown, if public health measures would have been taken on board seriously, closing airports, wearing masks, adequate PPE, that would have probably avoided the excess death rate. We've got 20,000 people who could have been, whose death could have been avoided if we had a week earlier lockdown. If we look at countries like Sweden, where there was only social distancing and no lockdown to create the so-called herd immunity, we see that that also results in an excess care home death number. Now, what we also need to look at with this is not just COVID, but as I said, the non-COVID related deaths. And these occurred because the hospitals locked down and care for the other diseases was suspended and delayed. And also people were reluctant to contact their GPs and go to the emergency because they either were afraid to get infected, or as a lot of older people said to us, we don't want to burden them. So the older people, especially the people in the private area and the British, Asian and ethnic minorities, were hardest hit by COVID, and also non-COVID related excess mortality. So we now almost have 50,000 deaths. And the government really needs to step up to avoid this for the second lockdown, which is probably going to come because we can already see the cases going up. Thank you so much.
Okay, thank you. Thank you so much, Eve.
Thank you.
Well, Eve is also an expert in dementia. So the third speaker is from Singapore. Ms. Thelma Kay is a former chief of the Social Development Division, United Nations Economic and Social Commission for Asia and the Pacific. She is also the former Senior Advisor on Aging Issues, Ministry of Social and Family Development, Singapore. Ms. Kay was a faculty member at the Department of Sociology, National University of Singapore. Ms. Kay currently serves as advisor and consultant to governments and international organizations such as Helps Age International and UN entities. Okay, Ms. Kay, please.
Mute.
Okay.
Oh, you're muted. Okay.
Yes.
Okay. All right. Good. Now I'm
Good.
okay. Thank you, Teresa, for the kind introduction. Greetings to my friends in Hong Kong and also to my ACAP friends and all my friends from many parts of the world. Let me start, as my time is very limited. Let me start, first of all, with the demographic landscape of Singapore, especially on items relevant to COVID-19. Singapore has a population of 5.7 million, which is less than Hong Kong's 7.5 million. Life expectancy is one of the highest in the world, like Hong Kong, over 80. And right now, 12.5% of our population are over 65. A majority live with their family, which can therefore provide support, but there's a growing number who are living alone. Home ownership is very high, which is relevant to and useful to having a place to go to during lockdowns or to work from home. Very few live in nursing homes, and most prefer to age in place. Oops. Okay, let me turn now to the epidemiology of COVID-19. The Singapore case is very interesting because I think like many countries, we had several waves. We started with the imported case from cases from China, and then that's led to, then we had local clusters, and then we had a wave of returnees from abroad. And then the last wave was a very, I think almost a very important wave for Singapore, and this was the migrant workers. From April 2020, we have about over 300,000 living in dormitories. So the total number of COVID cases is right now is over 54,000. And from this graph, you can see that the orange part is actually, most of them are migrant workers. And the ones you can barely see at the bottom are imported cases or community cases. But we are very lucky because the number of deaths so far is only 27, of which 95% are over 65 years old. So we have a dual track infection. One is low fertility infection levels at the community and very high infection levels among migrant workers, but still very low fatality. What has been the government response? Government response has been very vigorous. We have a multi-ministry task force, a whole of government approach. Of course, the usual very strict border controls, quarantine, stay-home notice, e-tracking device for travelers to Singapore, newly introduced, and the DORSCOM Orange. And then we have the testing, contact tracing, even have a list of places that were visited when people were infectious, and of course, isolation. In addition to that, a lot of emphasis now on physical hygiene, face masks, hand washing, physical social distancing, crowd avoidance. So a lot of emphasis is personal responsibility, as well, of course, as a collective responsibility, and very strict enforcement with legal regulation, maybe a bit unusual, but very strict. That has enabled very strict enforcement. And then from April to the 1st of June, we had something called a circuit breaker. Actually, it's almost a lockdown with only essential services in operation. And this was to reduce community transmission. So you can see here, this is the social distancing. And then right now, after the 1st of June, is phased opening. So now we are in like phase 2, safe transition. What has been the government response, additional government response? This is in terms of the budget. There has been 4 stimulus packages so far. And these packages have amounted to 19.2% of our GDP, and some have come from our reserves. And these packages have mostly been support for households, workers, and businesses, especially for those sectors most affected, like aviation, tourism, retail, F&B. So these are the 4. There are also, of course, other packages, like packages for the banking sector, and the Courage Fund is actually for the social sector. Turning now on to the direct impact on older persons. Like some of the speakers before me have spoken, there was a lot of shielding and protecting. So senior activity centers, over 70 of them were suspended. Senior-centric courses activities were also suspended. Seniors were encouraged to stay at home. You look here, seniors should stay at home. And then they were all separated from visitors, including relatives, and including non-co-residing grandchildren. At the nursing homes, we had 6 that were affected, and so there was heightened infection control and prevention, no visitors, split zones, caregiver management, etc. There was also a lot of support given to older persons, delivery of food and services. We had priority shopping hours, medical service, subsidized video teleconsultations for telehealth, customized entertainment, information, and also specialized activities. So a whole array of activities supporting older persons. I want now to turn to the 3 sectors, which I think there were some very nice innovative approaches. Well, first of all, first one, of course, was because of the high number of jobs lost and unemployment, focus on livelihood and jobs, because we want to save lives and livelihoods too. So as I mentioned, we had the government relief packages, and then there was a very important jobs and skills package, which is meant to help at least 100,000 people access jobs or pick up job-related skills. And here I want to also point out that there was a mid-career pathways program, because these are people who have to support families, including the elderly, and they have more expenses and harder to find new jobs. So a very interesting program is training in sectors which are in demand, with companies like IBM, with companies like Google for tech, with companies like Shopee for e-commerce, so very much in demand sectors. And then there were satellite job centers at the community level, virtual career fairs. So these are brought down to the community level. Let me turn down now to digitalization and digital adaptation, which, you know, Singapore is a smart nation. So we have, there was a big acceleration in digital use. And some say it was advanced by 2 years. So here, specific to COVID-19, of course, we have contact tracing, a very program we're very proud of called Trace Together, e-tracking for travelers, as I mentioned, and then safe entry digital check-in now that we are in phase opening. And then, of course, we have all these digitalization, working from home, online learning, shopping, entertainment, etc., and also telehealth, essentially teleconsultation. At the institutional level, we have set up a SG digital office with digital ambassadors to help 10,000 seniors. So, and I think this is of great interest. There's a senior Go Digital mobile plan, which gives reduced rates from telephone companies for seniors and also financial help for smartphones and mobile plans, and specialized training course for seniors and also market vendors so that they can, for example, adopt QR codes for e-payment like we see very much in China, for example. The third area I want to focus on is community support. And this is, we've moved from a whole of government to the whole of a nation or society approach with collective responsibility, with networks, partnerships. And then we have, of course, the 3 levels of government, institutions, and grounds up initiatives. We have a portal called SG United. I think you can check it out on the internet. It's the one-stop portal for volunteers, for donations, for support, for sharing. And you see a lot of volunteers recruitment. And
excuse me, Thelma, can you finish in 1 minute?
Yes,
yeah,
I will.
Thank you.
This is second last night. Community support, 2 main categories. One was for physical needs like food bank, community fridge, as you can see here, paying it forward. And then very importantly, a lot of effort for connections, for engagement, like befriending, digital literacy, like taking regular programs online. So my last slide is now, how do we live with the new normal? We have to live with COVID-19 until a cure or vaccination comes along. So I think for this one, we will need to continue with the prevention menu of mask, social distance, etc. We have to avoid complacency so that there will not be a new wave. And we are beginning to see a lot of social isolation, loneliness coming up of mental health problems. There will be accelerated digitalization for sure, with more work away from home, which is going to be the default way. And there are new ways of communication, transport, retail. Aging in place will come of age for sure after the incidences in the nursing homes, and more emphasis on becoming an age-friendly city. At the household, there will be more changes too. We're seeing more family bonding and even changing gender roles. There's reports that the males are doing more housework and more caring work. But will there be a rise in domestic violence? I haven't seen much evidence of elder abuse, but these are the changes that will take place in the household. So we're hoping not to see the rearing of ageism through intergenerational solidarity so that we can continue to build a society for all ages. So in other words, we all want to build back better together. Thank you.
Thank you, Thelma. Yeah, Singapore is really big in digitalization. Yeah. Okay, our 4th speaker is from India. Dr. Sandra Kala Diyali is a senior assistant professor in MIT Institute of Social Sciences at the MIT University in India. She holds PhD and MPhil degrees in social work. Her articles were published in reputed national and international journals, books and chapters, magazines, newsletters. Dr. Sandra Kala has been the core member to organize many national and international conferences, and organizes many university-level programs as a coordinator of many committees. So Dr. Diali, please.
Thank you so much, Professor Teresa. Thank you so much, ACAP and Golden Age Foundation for having given me such a big platform to present my story from India. Thank you. I'll just share my screen. Yes. So before I begin with this, chapter on psychosocial problems of elderly during the time of pandemic and ways towards its solution, a social work study on India. Before I begin with this topic of mine, I would like to just quickly go back to what interested me to do, why the study on elderly is because I was out for studies to Delhi. I was sponsored by government of India to study in Delhi University. So during that time, I left home very early in my life. And then, when I left home, my parents were young. But when I went back after having done my studies and all, so I got to see, them older than where I had left. And then, the kind of psychosocial changes that had occurred, so that really interested me. And I really wanted to work on elderly. So rightly said by Albert Camus, the old can go through every plough. His lines show us the way of wisdom to take the golden age population together, integrating them through the process of our pain, sorrow, struggle, and look up as we live through these troubled times. So, as far as COVID-19 effect on elderly in India is concerned, it has affected tremendously because they are very vulnerable population, not only in terms of health, even in terms of their psychological health, their mental health, their social, cultural, setup, and since they, 40% of the elderly, they depend on very low economic source. That's for the reason, they are very vulnerable. So when I saw all this vulnerability in elderly, then that interested me. So, then when I studied, the COVID-19 has changed the earth and future seems to be uncertain. So now it is a deadliest pandemic situation, and that has really affected elderly, and and because of their higher severity, prolonged illness and fatality of the infection. And so first of all, I would like to bring to you a physiological effect. Physiological effect on elderly is so high because of many causes. Because they are, the recent age-wise comparative study among hospitalized cases of COVID-19, it has shown that, higher susceptibility of the golden population age above 50 to this infection, and it has prolonged the duration of hospital stay among elderly, slow and sluggish clinical recovery, acute lung infection, faster development and progress of the infection, untimely higher mortality rate, increased requirement and use of mechanical ventilation and oxygen therapy, decline lymphocytes and C reaction protein in the blood that acts as an agent to suitable immune response to the virus, issues with decreased mobility, and prolonged chronic illness, multiple, as rightly pointed by Professor Eve, and multiple medication. There are many physiological limitation and infirmities related to psychological problems like problems in vision, hearing, that can work as a big hindrance to good health practices for the prevention, protection, and promotion of good health against the virus. So here, information, as far as information, in elderly among, about the signs and symptoms of COVID-19 is, it is, they are informed, well informed. it is 91%, and 9% they are not informed. And as far as psychological, impact of COVID-19 on elderly is concerned, it has really affected, because they are not only susceptible, but they have been, called as a source of infection to the other general population. So that's for the reason that has secluded them. It is the practice of, physical distancing, the social distancing, that has made them so isolated in their own homes and institutions. Okay, but government has got to realize that they are having psychological problems. That's for the reason a lot of good services, by Government of India and NGOs and many other institutions have come into being, like Ministry of Health and Family Welfare, NIMHANS, AIMS, and Helpage India. They have been helping them to go through this pandemic in order to help them to combat psychological problems. And feeling of confinement and social isolation, as far as Indian elderly is concerned, 39% are feeling so isolated, and because of that they are feeling lonely. And but they are not alone, as rightly very recently Professor Nandini, she is a professor. She had come to one of the news channel, and she said, yes, elderly are really psychologically affected and physically affected, but they are lonely. They are feeling lonely, confined, because the lockdown have been so long in India. But they are not alone, because people in and around, as you know, India is known for its community living. So community, family, the neighborhood, they're helping them to go through it. And mental health, yes, mental health has been affected because of the stress, the kind of news every day, the news channels are giving the rising death of elderly in the hospital, at their homes. So that is causing a lot of problem, and they are secluded at home, also in the institution. So they are very distressed, and they are bored. They are suffering with boredom, they are suffering with depression, they are suffering with a kind of unknown future for themselves, as far as their so yes, depression have been very, very cause of worry for government and health worker, and even their families and social worker. So worsening of chronic condition. Now see, they were already having lot of diseases from the beginning, but because of pandemic fear and all, they are having 58 people are affected. They are mentally affected, they are having depression, they are undergoing silent suffering. So, and government, non-governmental organization, and even social worker, they are helping them to come out of it. And economical, as you know, even in India, before pandemic, India was really going they were going rising in the employment of elderly, as far as participation of elderly in the workforce. It was going because of education, good bag,
Excuse me,
growth.
Dr. Diyali, can you finish in 1 minute, please?
Okay.
Thank you.
So economic impact on the livelihood of the breadwinner in the family. So socio-economic well-being also, because of congested situation, lack of inadequate access to healthcare support and services, lack of inadequate supply of clean water and hygiene, and lack of potential challenges to access humanitarian support and assistance. This causing, and nationwide this fear of infected by, they have a great fear, as I said. That's for the reason they have a lot of these problems. And economic loss, health anxiety, education of children, travel, they are not able to travel, meet their community, friends and all. So there are a lot of solutions: healthcare facilities, social care and support system, economic support system, legal and policy support system that are in place. So psychological security and all these are helping the elderly to go through this pandemic situation. And suggest, and few suggestions that have been at the national level given is financial help is very important, medical help is important, social pension, health checkup, screening of COVID-19 is very good, very important, mask sanitation, sanitizer use, and for everyone, ration, medical, social pension, door-to-door delivery of goods is very important for the elderly. Okay, so these are not only given at the national level by all these policy framers, but even with the participation of elderly in different nook and corner of the country, which is being surveyed by Government of India and Helpage India. They have surveyed, and these are the remedies that has come into being. Thank you so much.
Thank you. Okay, thank you so much, Dr. Diali, for your presentation. Okay, the last but not the least, we have our presenter from Hong Kong. Dr. Pamela Tin received her PhD from the School of Public Health at the University of Hong Kong. Dedicated to health systems and social development research, Dr. Tin and her team at Our Hong Kong Foundation published the policy paper Fit for Purpose, a health system for the 21st century in November 2018. The report was named Best Policy Study Report produced by a think tank by the University of Pennsylvania. And Dr. Tin is now head of healthcare and social development of our Hong Kong Foundation. Dr. Tin, please.
Thank you, Teresa, and thank you to the Golden Age Foundation and also to ACAP for this speaking opportunity. I will now share my screen. Bear with me for a moment. Okay. So today I'm here to really talk about how COVID has impacted Hong Kong as a whole, and also particularly for our elderly population. And so Hong Kong, we are a city with a population of 7.5 million, and the population density in Hong Kong is among the highest in the world. So as you can imagine, that puts Hong Kong in a vulnerable position for being particularly impacted by this COVID-19 pandemic. And sorry, bear with me, just trying to fiddle with my slides. Okay. Okay, yeah. So, and basically, of course, in facing the COVID-19 pandemic, Hong Kong does remember the lessons that we learned from the 2003 SARS epidemic, in which Hong Kong actually bore a pretty heavy burden, as you can see in terms of the actual cases that were confirmed or the people that were infected, and in terms of mortality. And but in terms of actual individual behavior, we also remember vividly the lessons we learned from this epidemic, including sort of adopting behaviors such as wearing face masks, hand hygiene, using tissue papers to press lips and so on. So that's sort of embedded in our culture and readily acceptable as we face the COVID-19 pandemic. And of course, we took these lessons to heart, where of course the government also had relevant policies and regulations in place to put Hong Kong in a position where we are ready to face future public health threats as such. We are now facing the COVID-19 pandemic. So how has Hong Kong done in terms of tackling this worldwide pandemic? The government, of course, has in place a suite of public health measures, including, as previous speakers I'm sure has already mentioned, in various countries we have put in border controls, social distancing measures such as work from home arrangements, closure of schools, etc., screening and surveillance measures, contact tracing, quarantine mandates, so setting up quarantine centers in community settings, testing procedures, and of course, one fundamental part, of course, is properly delivering or doing risk communication with the public, so that the public is kept fairly well informed of what's happening in terms of the COVID pandemic particularly the Hong Kong situation. And as you can see, though, of course, there is no time to relax, because at the present moment, Hong Kong is undergoing its third wave of the COVID-19 pandemic, unfortunately. And as you can see on the slide, the graph vividly shows that, the third wave is, there's a steep increase in terms of the number of people being infected and the number of deaths being recorded. And so the tally is currently, the total number of cases is close to 4,000 as of today, and also the number of deaths has reached 46. So that's very unfortunate. But amidst all that, of course, the Hong Kong population, about 18% of our population is aged 65 and above. And so one of the major emphasis has been, what has been done to help the elderly population in Hong Kong amidst this public health crisis. And so, of course, lessons learned from SARS again, there's already quite a bit in place in terms of government policy, and one of the things that's worth highlighting is, for example, the Social Welfare Department in Hong Kong has mandated strict regulations for elderly care centres that really helps to minimize the opportunity for outbreaks within these centres. So, for example, of course, reductions in contact with off-site visitors. So, for example, with loved ones who do not reside in elderly care homes, the suspension of services within daycare centres, and also limitations for at-home and community-based services. And amidst all these bans and all these social distancing measures, elderly care homes, and of course also services in community settings have strived to maintain as the services providers as much as possible. And of course, our care service providers are to be applauded for the efforts for trying to maintain such normalcy. And so initiatives by NGOs and the private sector are to be noted to substitute suspended services, such as in terms of sensory stimulating activities. So really sending, for example, care packages to the elderly who reside at home to keep their cognitive function going. So like these packages would have games that stimulate cognitive functioning. And so emergency support networks have been set up, networks of nurses and medical practitioners really on call to go to individual elderly residing at home when they need that medical support. And also financial support has been in place. But one of the things that's worth highlighting is really the role of technology within all these efforts to maintain normalcy of elderly care services. This can be exemplified by, for example, adult day care centres. They have suspended the services, but they have provided tablets to elderly who stay at home and basically have health monitoring functions that monitor the health status of the elderly, for example, blood pressure, heart rate, so on, and any abnormalities are conveyed straight away to daycare professionals. And also within the same tablet, there are functions, as you can see on the screen, that's like what you can see in the tablet. There are options for interesting games, sort of to keep the elderly active, sports videos, and also, again, cognitive games that sort of facilitate the maintenance of cognitive functioning. So this is all for the to help the elderly individuals stay healthy as much as possible. And also, as mentioned by previous speakers, so from New Zealand, from India, and also from Singapore, we are at risk for there being a loneliness pandemic within our elderly population due to all this social isolation regulations. And so, of course...
Hi, Dr. Tin, can you please finish in 1 minute?
Yes,
thank
definitely.
you.
So of course, this is an example of, again, technology, innovative technology being used to tackle this potential loneliness pandemic. You can see this AI robot. It's a chatbot really used within an elderly home to maintain communication between the elderly in elderly homes and off-site loved ones, so through video conferencing. And so basically, in summary, really, it's to be noted that as we move towards a new normalcy, a post-COVID new normalcy, technology is going to play an important role. And one of our research reports launched in 2017 on germ technology has identified major gaps in the germ technology ecosystem in Hong Kong, including funding gaps, loss of testing ground for new products, and also the society's general lack of awareness for the impact of technology. But of course, apart from thinking of the challenges that COVID-19 has brought us, we must also seize this golden opportunity to move forward and really look at how we can leverage on technology, particularly germ technology, so that we can continue to help and deliver care to our elderly population so they can continue to thrive and be change makers in our society. Thank you.
Thank you so much, Dr. Tin. And thank you all the speakers for your very inspiring presentations. So without further ado, I would like to open up the floor for question and answer. So I have received quite a number of questions here, and these are all addressed to all the speakers. So if you have any comments, please feel free to address to them. So the first question is that the social distancing policy has adverse effects on the elderly because they increase loneliness, mental stress on both the elderly and caregivers. So are there any effective ways to help them, to all speakers?
So perhaps I can elaborate a little bit on one of the slides that I was talking about. Again, there's this possibility on leveraging on the role of technology in possibly helping this. I had mentioned that to be, the example I mentioned was a chatbot, or really an AI robot that really helps the elderly within elderly homes to communicate with their loved ones outside of the elderly home by digital means. And the robot I was talking about, there's a lot of new initiatives that could be played. I mean, it's sort of automatic. It can go, it's pretty good at sort of going at different places within the elderly home, even for bedridden elderly who can't really get out of bed, but then the robot can actually go to the bedside, so that can maintain the communication between the elderly residents and also their loved ones. Of course, apart from that, in terms of health care delivery, for example, telemedicine is probably something that's gaining momentum in terms of development in the society amidst the COVID-19 pandemic, where, for instance, in Hong Kong, we have community geriatric assessment teams from that's really a geriatrician nurse-led initiative that reaching out to the elderly care home residents within in Hong Kong and providing suitable care, including healthcare and social care to residents, really making it unnecessary or lessening the chance for the elderly who need care to go to medical care facilities or hospitals that would possibly put them at higher risk for infection.
Yeah, thank you, Pam. Any response from the other speakers?
Can I ask Pam a question? In relation to the technology that you're speaking of, what is the general level of literacy amongst older people of technology? In other words, is what you're talking about commonplace, or is it only for a small number of more technologically literate older people?
Yes, indeed, of course, the health literacy in regards to technology among older people, it's generally gaining momentum. As one of the panelists in an earlier session, Dr. C.C. Lam had mentioned, for example, of course, he showed a graph where in terms of Hong Kong, the use of technology among the elderly, the percentage of elderly knowing how to use, for example, gadgets, technological gadgets, and also mobile phones has been increasing. In Hong Kong, the figure stands at, I think, approximately a third of the elderly population has owns a smartphone. So basically it's sort of gaining momentum. True that, of course, a lot more can be done in terms of improving that sort of literacy, but it's getting there.
Well, thank you. I think you have also answered the second question about technology literacy. So, but another question is that though technology could, help hugely, but it cannot replace human touch. What do you think?
Well, that was behind my question to Pamela before, really. I mean, social relationships are crucial to people, whatever stage of life. And it seems to me that, I mean, technology can assist, but I think there are other ways in which people need to be able to, or older people need to engage in society. And I was really quite interested in some of the comments around in care facilities and the ways in which quite a lot of the older people, in a sense, are it's like enforced isolation. I mean, they may have contact with a few people, but outsiders, so to speak, may not be able to come into those facilities, and so it kind of makes things worse in some respects in terms of isolation. So, I think the speaker from India talked about this psychosocial kind of aspects of what's going on, and just how important they are that we deal with those. And in the organisation that I mentioned around Age Concern, we're trying to do our best, but we're just one NGO amongst lots of other providers. And I guess one of the issues that arose for me too was the extent to which these facilities are state provided as opposed to more independent providers. Does anyone have any comment on that sort of issue?
Can I just say something about this, because we've been doing a lot of work with technology, and I agree with Pamela that we can see in the UK that increasing numbers of older people are becoming more literate with tablets and keeping that contact, but it needs to stay at a simple level, I think. Sometimes I find actually the simplest solutions, the sort of grassroots solutions work really well, where, for instance, people had put up plastic sheets in the garden to go and hug their elderly, which were really very lovely ways of still having, that human touch.
Yes.
And I think it's very important. What a lot of people have done is go and visit the care homes, but stay behind the glass and just wave at people and just be there, and I call my mom every day, a couple of times a day, just to catch up. And there's lots of TV programs in Holland set up for older people with exercises, cognitive stimulation, quizzes. And I think, talking to the elderly in Holland, they feel sort of that state support. It's free. It's very easily accessible. My worry is often, and I think I agree with you, Brian, is that a lot of the technology is taken up by the people who can afford it. They're highly educated. They're very well connected usually anyway. They have a lot of support networks. And what we can see is that the people most affected were the very old, the very frail, the isolated, the poor, British, Asian, and ethnic minorities, where one of the issues was actually living in cramped conditions and not being able to get away from each other, living in multi-generational households. So it is very important to make sure that we can shield the elderly from this and still maintain that social contact. But I'm a big believer in technology myself, but sometimes I think, as I said, the very simple sort of, that plastic sheet in the garden worked really well in the UK. It was taken up quite widely.
Hello.
Yes.
If I can also
you're
add
mute.
here, can
Yes.
I add here what Professor
Sure.
Eve has said? You know, in order to combat the psychosocial problems in India, what our police force have started doing is even celebrating, getting to know about registering their birthdays and all, and going to elderlies and celebrating their birthdays, and you know, replacing the social physical distancing with social distancing. They are not supposed to maintain social distancing. It's a very, very wrong concept. So okay, maintaining physical distance, you can always make them feel good. And teleconsultation is one thing that India has been emphasizing on, so that the the elderly would not have to go to the healthcare centers and institutions. So they are given consultation, and for minor problem, if any surgeries and all, surgeries are there which is not very urgent, that can be postponed, that can be done, conducted after COVID. So all the safety measures, that is best practices, not only medical ground, but even their own traditional, how they have been so resilient and overcome all the health problems past in their lives. They have to go back to their tradition and find out as how their people traditionally have combated the problems such pandemic or any kind of epidemics and all. So that is another, and use of best practices, how to maintain hygiene and all, how to not live in cluster. That's for the reason, every schools and every open spaces have been converted into hospital and isolation center for elderly. So these are the few measures, Indian government have taken up. Not only Indian government, but NGOs have been partnering with government initiative with their excellent and innovative way to handle COVID-19 in terms of elderly. Because as we all know that India, we really want to have a community living. Family values are still intact. So, and joint family system is still now government has come up with another measures of living with joint family. Now people in urban area had already started separating with their parents and all elderly. Now government of India is enforcing with its policies that no, we've got to go back to our root and get our joint family system come back. That is the way I feel. These are best practices that government of India is doing.
Now, share some examples from Singapore. We make use of the telephone a lot because most households have telephones. So, not so much. And so there are befriending services where actually people are matched to the elderly and they can call them and check up on them and you can become a friend through the phone. Also, we have a lot of volunteers, younger volunteers who will then match up with the elderly to be their friend. So there are a lot of on the ground practices going on. Although technology, of course, is being pushed because we have to enter into the technological age. But then there's still a lot of transitional measures that can be used. So I think we have to have a mixture of both and then gradually introduce our seniors into the digital age. But you are right about, I think, social isolation and all these very harsh measures. I think we have to be a bit kinder to our elderly because all this lockdown. In Singapore, we've had cases of the elderly being the ones that are being sort of, I wouldn't use arrested, but sort of they're the ones who are wandering around during breakdown, sometimes because of being cooped up at home. So maybe a little bit more understanding towards the situation of the elderly, especially those who are a little bit not so well educated or in very difficult circumstances would be, I think, very welcome. Be more understanding, be kind.
Well, thank you so much for the discussion. Actually, I got a lot of questions and some particularly to specific speaker, but because of time, I will only maybe ask all the speakers for one last question. COVID has given valuable data globally for local government to address the existing and potential problems in the community, especially the underprivileged. Interested to know how government from different countries, the policies, the economic, social, technology factors affect the pandemic outcome. This is a very broad question to everyone. So maybe you can just say,
just a brief comment that I think one of the successes for New Zealand has been the leadership at governmental level and the constant communication with the ordinary person through appearances, regular appearances on television as to what exactly is going on. And so it's a combination of the national, of the local, NGOs and families, you know, a concerted effort. That the Prime Minister speaks of a team of 5 million. And that's the kind of message that I think is important.
Thank you.
If I can say a little bit about the UK, I think we've had the opposite response. We've had very confused messages: go out, stay in, wear a mask, don't wear a mask, go on public transport, work from home. We had Dominic Cummings going off and traveling, and that was perfectly fine. Today a report came out showing that particular instance where the government seemed to have one rule for the public and quite yet another for the people who were on the top, created a lot of public mistrust, and the population is really confused. Yesterday I was in the shops and somebody said, but it's all over now, we're fine. And I said, it's not, the virus is still here, we're having an increase in cases. The public health message, very, very unclear. And I think one of the problems is that experts, as Michael Gove said very early days last year, we don't need experts. Who needs experts? And that is very much the tenure. They just want to get back to getting the economy rolling. People are very afraid of economic recession, and that's badly backfired. It was very much an idea that herd immunity would work, but we knew from the start, the scientists said, this will be to the detriment of older people, and it has. We've had a tremendous number of older people die, and I think, you know, looking at the other speakers in the other countries, I feel quite ashamed of the governmental response. I think it's really shambles, but you know, it is what it is, and I think we're looking at a second wave, which is going to possibly be even worse, because there's no we dismantled, like the US, we dismantled our emergency governmental viral response teams. We did it because of Brexit. That was deemed to be more important. The US did it because it was Obama's plan and Trump didn't like it. And we can see it in the numbers of people who've died. You know, we need to work together. We need to learn from each other, but there seems, you know, our testing and tracing is still not working. And I think that's one of the major reasons why the East Asian countries have been so successful. Ours doesn't work. We've paid millions, and we should have worked together with countries where it did work. Anyway, that's...
Yeah, I want to add something. I think the motto should be all hands on deck. Let's all work together towards this. The government, of course, has this role, a very important role of a policy, of regulation, of budget, of providing information. And then we mustn't forget the institutional, the corporate sector, and of course, at the end of it, the grounds up thing, the grounds up movement, which we are beginning to see in Singapore. But I think we also have to put aside political differences and then realize that we all have to work towards one goal. And this is, how do we live with COVID and after, and how do we cope with COVID? This is going to be our big goal.
Well said.
You know, yeah, if I have to talk about India, yes, as rightly said by Professor Brand and Professor Eve, you know, political will is one thing, you know, political will, the leadership You know, as far as leadership in India is concerned, you know, he's very popular leader. You know, Modi is doing every bit to protect elderly, general population and elderly in specific. He himself is in that age group, so he understands the vulnerability of elderly. And when 40% of our you know, elderly population is living below poverty line, so he has strictly, very stringently you know, given the mandate to everyone that lockdown should be practiced widely. And he said nothing before, you know, the life of people and elderly. We have to shut down everything. Yes, economic vulnerability and economic challenges are there for developing, fast developing country like India, but at the face of economy, at the face of life of elderly, we have been practicing lockdown very, very sincerely. I think India is really come to the global, you know, picture about how lockdown is being practiced widely. And then even schools and every institution, even, you know, healthcare system and everywhere, in even elderly homes and all, they are practicing you know, physical distancing, not social distancing. But and then, you know, another thing is, like, you know, every you know, community is, and we are not only depending on government, even at the community level. Recently we had a survey in our Amity University, had a survey in one village, whole village in Uttar Pradesh. There we wanted to know as how they are combating this COVID-19. So they said, as community, we are trying to protect our elderly, and not at the local level. In the sense, small communities are coming together very collaboratively, and they are, you know, people who are not having means of supply for food and basic needs, and they are being provided by the community, and they are having community cooking. You know, every community is coming together, and we are, and there is wide distribution. Some organization I know about, you know, Robin Hood and all, my friend is involved in. You know, they are cooking every time, and they are distributing to every you know, healthcare institution, and even at the community level and all. So this is how India, you know, if every local community, you know, cooperate and collaborate with each other in order to help each other at this critical situation, I think COVID-19 and pandemic is nothing in the face of cooperation and collaboration. That's what, you know, I feel. I give a call to global leaders that we all should collaborate. We should not only, you know, look up to the data and, oh, it's rising, it's going down. It's, you know, we have to cooperate, and the best practices that are being used and that have been successful, that has to be adopted by every developing and underdeveloped country like Bangladesh and Nepal and all that they are doing. And Nepal is one of the, you know, underdeveloped country, but I have read on the research paper that, you know, they are combating COVID very successfully with community participation and collaboration. Thank you.
I just add one quick comment. So no, I totally agree with all panelists. There should totally be both top-down and bottom-up approaches. Back in Hong Kong, of course, as I briefly mentioned in my presentation, you know, the government has been doing risk communication via, say, daily press conferences. They set up a specific website for the latest COVID information, so that to keep the public informed, and of course, bottom-up initiatives from NGOs, from the private sector, and from, you know, individual behavior from the citizens of Hong Kong. This all contributes to our successful combat to this pandemic. But also completely agree with Chandrakala, you know, basically there's a need for international collaboration as well. I know of an initiative, for example, of global think tanks joining efforts really from all over the world, really putting their minds together and thinking of policies that we need in order to not just deal with the current pandemic, but also how we can together cross borders face any future public health threats as such. So all in all, collaboration and working together is super important.
Well, thank you so much for all the, wonderful, very inspiring presentations. So time is really running short. I think next time we should have a longer session. So finally, I hope that you have enjoyed and learned as much as I have from all the speakers and also the questions from the participants. And by now, I think we all have a better understanding about what's going on in different countries in addressing the issues. So my take-home message is that we have to learn to live with COVID-19 as it will be part of our life and become our new normal. Secondly, I think from all the speakers, we need concerted efforts from government, business sector, NGOs, and individuals to connect and to support our elderly. And thirdly, technology helps to connect elderly to family and community, but we have to be aware that human touch is important. So finally, I wish to make a pledge to say that we don't wait for the perfect life, but I think together we can make our life perfect. So in concluding, I want to thank the organizers, the 5 prominent speakers, all the staff and volunteers. Especially, I really want to thank Professor Brown for hosting this platform all by herself at midnight in Hawaii now, because now it's Hawaii time midnight. So last but not least, I want to thank every one of you for joining us today. We'll have another ACAP International webinar on 22nd of August at 11 a.m. Hong Kong time. So please mark your calendar and we'll keep you posted. So I would like to thank you everybody for joining me today. Stay well, take care, and goodbye for now. Bye, everybody.
Bye.
Thank you. Thank you so much.
Thank you.